Well, greetings everyone, and welcome to the EKG case for the week of April 22nd, 2012. It just came off a couple of weekend 3 to 11 shifts, and it was incredible the number of highly sick patients and great pathology that we had through the weekend. There was count them, three aortic dissections. All of them were type B dissections. And we have a lot of untreated hypertension in the city. We saw a few other hypertensive crises, including these dissections. And I think there was a saddle embolus. Now, we have a large emergency department, so we have double coverage. And every one of these cases went to my colleague who's working in the other area of the emergency department. The only thing that I got to see, despite all these great cases coming into the ED, the only cases I think, or it seemed that I got to see, were prisoners in shackles that were suffering from acute Haldol deficiency. Honestly, it was awful. But the, I guess the one good thing that happened over the weekend was a physician in Malaysia, sent this EKG to me, and it kind of made my weekend. And granted, I probably need to get out a little bit more, but that's how bad of a weekend it was, that a simple EKG could really make my weekend. It was an interesting EKG that he sent. This is, I think, a middle-aged patient. I don't have all the clinical details, but a middle-aged patient that came in, and I don't even know what the patient came in for, but there was a great rhythm that we had a chance to discuss. We talked about it over the internet, and I wanted to share this case with you, and he allowed me to share this case with you also, though he didn't really care to have his name on this EKG because I think the EKG came from his student. But anyway, it was a great case, and my thanks if you're out there listening. So, what you'll first of all notice, perhaps, is some T-wave inversions in the anteroseptal leads. And actually, for this EKG discussion, we're not going to talk about the ischemic findings. We're just going to focus on the rhythm analysis here. Now, when you are looking at an EKG rhythm, there's three simple steps that I like to think of doing. Number one, take a look at what the ventricle is doing. Number two, take a look at what the atrium is doing. And then number three, try to figure out what the relationship is between the atrium and the ventricle. How do you do that? You'll look at the PR interval. So first question, what's the ventricle doing? Well, the ventricle is beating at a rate of approximately 65, and these are narrow QRS complexes. So that's pretty good. We like seeing rates in that 60s to 70s to 80s type of rate. So we're pretty happy with what the ventricle is doing. Easy enough. Second question, what's the atrium doing? So now it's starting to get just a little bit more interesting. And what you'll notice is that there's a regular atrial rate marching out there at a rate, if you map it out, you can take my word for it, the rate comes out to be approximately 125 beats per minute all the way across the 12 lead EKG. So it appears to be some type of atrial tachycardia. Now, is this an atrial tachycardia or is this a sinus tachycardia? And we might be reviewing something now that maybe we have or haven't reviewed before. But how do you know when the atrial beats are emanating from the sinus node? Well, by definition, sinus beats should have upright P waves in all of the limb leads except for AVR, in which case the atrial beats should be inverted. In this particular case, you don't really see any good clear-cut P waves in one or maybe an AVL, maybe, I'm not sure, there's a little artifact in there, but we'll just give those two leads a bye. We'll ignore those, but it's clearly upright in 2-3 AVF, clearly inverted in AVR. I think it's reasonable to assume that this is a sinus tachycardia with the rate of 125. It's also a reasonable sinus tachycardia rate. You know, if you saw an atrial rate of 190 or 200, then that's not a sinus rate unless it's a kid. Adults really should not be able to mount a sinus tachycardia that fast. And again, just as another aside, you may ask, well, how fast can the sinus node beat? Generally speaking, and nothing in medicine is 100%, but generally speaking, the maximum sinus rate a person can achieve is 220 minus their age. So let's say that this is a 50-year-old patient. 220 minus 50 is 170. So the maximum sinus rate that this guy could achieve would be a sinus tachycardia of about 170. If you got up to 180, 190, it's probably not sinus tachycardia. It's probably an atrial tachycardia of some type. Okay, so we've got the ventricle beating narrow at 65. We've got the atrium beating fast, sinus tachycardia, at a rate of 125. Now, the third question is, are they talking to each other? What's the relationship between the atrium and the ventricle? And how do you know what the relationship is? Well, what you need to do is you always need to look at the PR interval. So, taking a look at the PR interval, we'll start out on the rhythm strip on the bottom at the very left, and you see right here that there is a small P wave that's buried right at the very beginning of that QRS complex. They're pretty much fused together. So there's practically no PR interval at all in the first beat. Then you've got a really long PR interval, and then another one which is still pretty long, and then moving forward is still relatively long. It almost looks like it's getting shorter, and shorter and shorter and shorter. And then I suppose if we kept going in that direction, we're probably going to get another fused P-QRS complex like over here. So what in the world can it be when the PR interval is getting shorter? Now, we'll review for a moment the different types of AV blocks. Well, let me go back for a second. Whenever you see that there's more P waves than QRS complexes, it means that there's some type of AV block happening. Not first degree AV block, but we're talking second degree AV block type 1, also known as Mobitz 1, also known as Wenckebach, or it could be second degree AV block type 2, also known as Mobitz 2, or it could be third degree AV block. Those are the three choices. How do you know when you're dealing with Mobitz 1 versus Mobitz 2 versus third degree AV block? Recall that the definition of Mobitz 1 is that the PR intervals should gradually increase and then you lose a QRS complex. With Mobitz 2, all of the PR intervals should be constant and then you lose a QRS complex. And in third degree AV block, it is none of the above two. Okay, it can be a random series of PR intervals. As long as you realize that third degree AV block means that there's an AV block, but it's not Mobitz 1 or not Mobitz 2. We'll go back to that 12-lead EKG and ask those simple questions. Are the PR intervals gradually increasing and then there's a dropped beat? No. So therefore, this is not Mobitz 1. All right? Next question. Are the PR intervals staying constant? Well, we've already established that they're not staying constant. Therefore, this is not Mobitz 2. And so it actually becomes very simple that this, by definition, must be third degree heart block because the PR intervals are changing, but they're not gradually increasing, so it can't be Mobitz 1. The PRs are not constant. It's not Mobitz 2. So your final rhythm analysis is sinus tachycardia with a rate of 125 and complete heart block, and there's some type of escape rhythm. It's narrow. It's a junctional rate of 65. Remember, the AV junction usually beats at 40 to 60, 60s or so. So this is sinus tachycardia with complete heart block and a narrow junctional escape rhythm. Very simple once you break it down. So again, when you're looking at rhythms, first step, what's the ventricle doing? Second step, what's the atrium doing? Third step, are they talking to each other? And if so, how are they communicating? And the way that you do that is to look at the PR interval. Very, very simple. All right, so hope that was helpful. Just a really quick, simple case. And we'll do more dysrhythmias as we go. I've got some feedback saying that people want more dysrhythmias, so we'll try to get those on board. Until next week, take care.